This lecture introduces you to an RPD design called the Rotational Path Removable Partial Denture. You may find this design an advantage when you wish to create an aesthetic solution for a patient. It is one partial denture design that takes you into the world of aesthetic dentistry. Missing teeth can be replaced using any number of methods. A fixed bridge or prosthesis retained by dental implants may be used to replace missing teeth. When it is necessary to replace anterior teeth, as in the Kennedy Class 4 on the left, or long span edentulous areas in the posterior, as in the Class 3 shown to the right, then a properly designed and fabricated rotational path removable partial denture can be both successful and aesthetically pleasing to the patient. These two cases on the left are examples of rotational path removable partial dentures replacing anterior incisors. While a patient's functional and aesthetic needs can be met with the rotational path RPD, they can be more demanding for the laboratory technician to fabricate and for the dentist to seat in the mouth. This decision is often overlooked as a viable means of treating missing teeth for this type of partially edentulous arch. This lecture gives you the principles of rotational path removable partial dentures, as well as defining their categories, advantages, and disadvantages. Hopefully, you will go out and practice and consider this as a means of replacement for these indications. The advantages of using the rotational path RPD is in the minimization of the use of conventional clasp. It is achieved without compromising the requirements of the direct retainer. Because there is less metal around the tooth surface, it also enhances the oral hygiene. Lastly, in cases of anterior class 4 edentulism, as shown on the picture on the left, the rotational path can be very aesthetic without any anterior clasping. The direct retainer requirements are satisfied through incorporation of a rigid retentive component indicated by the green arrow on the guide plate, in conjunction with a specially designed type of rest, which is the long occlusal rest. The rigid component of the removable partial is seated into the undercut in the anterior and is maintained by intimate contact with the tooth surface as the partial denture rotates into its terminal position, engaging the undercut on the posterior molars. It is absolutely critical that the posterior clasp have good retention and be positioned in an ideal location on the tooth. The retention on that tooth should not, therefore, be in the occlusal 1/3, but rather in the cervical 1/3, or at worst, the middle 1/3 of the tooth. Notice the design of the rest for the rotational path RPD. It must prevent the migration of the abutment tooth when the partial denture is in function and when that edentulous area is loaded. It does this by extending all the way up to the distal fossa. The tooth cannot tip because it is being held in place by the distal aspect of this rest. The effectiveness of the rigid retentive component, in this case on the guide plate, on number 31, depends upon the conventional clasping used in the design. The clasp used on number 29 should encourage stability by its design. Direct retainer arms should be placed favorably in the cervical 1/3 of the tooth to fit the design rules. Therefore, tooth alterations to lower the survey line may be necessary to develop the proper positions for the direct retainers and the reciprocal components. The reciprocal components, as you've learned, need to be no higher than the middle 1/3 of the tooth. When the RPD is rotated into place and seated, the rigid retainer remains passive since it has absolutely no flexible components. This slide shows two applications of the rotational path RPD. The one on the left has no clasp arms on the posterior molars, with retention coming from the rigid component placed on the mesial surface of the molar. This is very advantageous when the posterior molar is tipped severely to the mesial and to the lingual. You would have to mutilate this tooth to adjust the lingual surfaces in order to position the clasp arm in its proper position. One type of rotational path removable partial denture is the anterior-posterior rotational path prosthesis. It may be designated on some of the slides as the AP rotational path prosthesis. The illustration on the left shows the path of placement for this removable partial denture at its initial seating that rigid component first. On the right, we see the final terminal position for the AP rotational path partial with the posterior clasp engaging the molar. The anterior segment of the partial denture, which is the rigid component, is seated first. Then the remainder of the prosthesis with its flexible clasping component is rotated into position. The rigid component and the posterior direct retainer component are passive when the partial is in its terminal position. The rotational path may be employed to great aesthetic advantage when anterior teeth are missing, since no labial clasp arms are visible or used with this prosthetic design. The posterior ones are present, but they don't show that much. Compare that one on the left with what you see up above on the right. The rotational path permits reduction of tooth coverage, eliminating direct retainer arms, thereby reducing possible plaque accumulation in the area and possible decay. To replace posterior teeth using a rotational path RPD and its principles, you should have a relatively long edentulous space because of the demands for rotation of the prosthesis around the abutment tooth's proximal surfaces. If you have a long edentulous space, you have two options available. One is the anterior-posterior rotational path design for posterior teeth, and the other is the posterior-anterior, or PA, path design. These are both designated by the position at which the partial denture is initially seated, followed by the position at its terminal placement of the prosthesis. When posterior teeth are missing bilaterally, either the anterior or posterior segment can be designed to seat first. It depends on the following considerations, along with the fact you're going to have some undercuts, proper undercuts in the position. If you are trying to achieve aesthetics, then you would want to eliminate any anterior clasping, in which case you would choose the anterior-posterior design for the rotational path prosthesis. It may be a periodontal factor like oral hygiene that makes you want to choose one over the other. Either one may be chosen, but it seems most likely that hygiene is a problem on the posterior molar over the premolars. And lastly, you may have a posterior abutment tooth that does not have an ideal position in the arch. An example of this is that posterior abutment tooth that leans severely to the mesial and to the lingual, and you do not have a good design option for placement of the direct retainer. This may drive you to select that long rest on the posterior abutment, leading to a posterior-anterior rotational path design. Usually the anterior-posterior path is used on the maxillary arch for obvious aesthetic reasons, eliminating clasp on the anterior abutments. I add just a note about this case. This partial, if completely seated, does not demonstrate a posterior clasp design that affords good stability and retention, which is critical for the success of the rotational path denture. Note that the retentive or reciprocal arm is located in the occlusal 1/3 of the tooth. Where should these be? Posterior-anterior rotational path designs may be used to great advantage where mandibular molars are tipped mesially. Clasp arms on these molars are eliminated, resolving the difficulty of clasping these teeth without crowning or mutilating the tooth during mouth preparation for the design. With any of these teeth that receive the rigid component of the rotational path RPD, be it anterior-posterior or posterior-anterior design, the amount of tooth coverage by metal is reduced, and therefore the accumulation of plaque and debris are also reduced. The utilization of undercuts by the minor connectors or proximal plates is always done in conjunction with clasp on other teeth to meet the requirements of sound direct retainer construction. This partial framework demonstrated here was actually redone. It utilized too much of an undercut on that posterior molar, which inhibited the rotation of the prosthesis into place. It did not allow for proper design of a good guide plate on the anterior abutment and for ease of placement of the anterior clasp assembly. A lateral rotational path of insertion may also be used when anterior teeth are missing unilaterally. Clasp arms are eliminated on anterior teeth, and one or two clasps are used contralaterally on the posterior teeth. The design for this RPD shown on the previous slide, which I found in an older textbook, bothers me a little in that I fear for the stability of this partial and the way it crosses the palate obliquely. The brain doesn't like a major connector that cuts across obliquely on the palate. Design number 2 offers more retention by adding another direct retainer and a reciprocal arm on tooth number 4. But the position of the new direct retainer on 4 offers more complication to the seating of the direct retainer, as it must be seated with that retentive tip touching first. It counteracts rotation from an anterior direction when the patient eats sticky foods. Design number 3 offers the advantage that it allows crossing the palate less obliquely without making the partial more unaesthetic. Design number 4 is more bulky than the others, and it allows for crossing the palate more perpendicular to the median palatal suture, but covers more palate and will be less aesthetic when the patient throws his head back and laughs. What do you think? Note the differences in the design. Number 1 was the one that was picked by the dentist. Is anybody wrong? A lateral rotational path may be used when posterior teeth are missing unilaterally. Undercuts may be utilized on the mesial buccal and distal buccal, or the mesiolingual and distal lingual of the abutment teeth on the edentulous side. A conventional clasp is utilized on the opposite side of the arch and must satisfy balanced retention. Do you remember what balanced retention means and how it affects the positioning of the partial denture? Here are some rest and rest preparation considerations for a rigid retainer. The rest preparation must be prepared deep enough to allow for a rest thickness of 1.5 to 1 3/4 millimeter thick for chrome cobalt alloy and 1 3/4 to 2 millimeters for gold. The rest seat should be prepared with relatively parallel walls for the rest to provide a bracing type of situation. This is comparative to our regular rest preps, which we would like to see more spoon-shaped and definitely not with parallel walls. The rest seat must be prepared parallel to the path of insertion and parallel to one another, or else the partial framework will not seat. The rest seat should be extended to more than 1/2 the mesiodistal dimension of the clinical crown. This provides a good positive seat and prevents further tipping of the molar in a mesial direction. It also stabilizes the partial denture under function. The picture on the right shows the use of a long mesial rest for prevention of tipping of that particular molar, even though you see clasp arms on that. It's not used just for rotational path partial dentures. It can be also used for regular designs. Use of asymmetrical rest seats, like dovetails, will provide the equivalent of an adequate encirclement of the clasp. Often, conservative restorative treatment is necessary to provide for an ideal rest. When a restoration is placed, care must be taken to make sure that it is thick enough after preparation to ensure that the restoration does not fracture under pressure from the function of the partial denture. If you look at this illustration, on the left side, lingually tipped mandibular molars have occlusal rest seat preparations made that are parallel to the long axis of the tooth instead of parallel to the path of insertion. Doing this technique creates undercuts in both abutments, which prevent the rest from seating completely when the final partial is rotated into its terminal position. On the right side, the rotational path RPD rest seats are prepared perpendicular to the floor of the mouth with parallel facial walls. These rest seats are prepared to accommodate for the path of insertion for the partial. This permits seating of the rest when it is placed and put into its terminal position. The advantages of a rotational path removable partial denture over a conventional design are: it minimizes the number of clasps. The anterior clasp may often be eliminated, thus improving the aesthetics of the case. There's no distortion of rigid retentive components. It may often be used in the absence of lingual or buccal undercuts. It minimizes tooth coverage. It may be used in preference to the anterior fixed prosthesis to attain better aesthetics. It is easier to maintain oral health and hygiene over the conventional clasping system, and there's minimal tooth preparations with this. Now for the disadvantages of the rotational path. First of all, there's no adjustment of that rigid retentive component if a problem exists. There is little or no tolerance for error both on the part of the dentist and on the laboratory. It requires well-prepared occlusal rest and cingulum rest seats. May require conservative restoration if the dentin is exposed to develop an acceptable rest seat. It is more technique sensitive for the laboratory technician, and it is a removable prosthesis in the end instead of a fix that doesn't have to come in and out of the mouth. It is also more difficult to seat if the dentist has some types of problems than a conventional partial denture. We are going to go over some of the steps for various rotational path design options, but first we have to get the usual diagnostic information required prior to a removable partial denture consult and treatment planning session. You're going to, 1, do a complete exam on the patient. Whatever you do, get diagnostic casts on the first visit. That way, if you have to make occlusion rims to mount the case, you will not waste an appointment. You'll then obtain jaw registration records using your occlusion rims, mount the case, make sure that you have good radiographs of the patient, and you will survey and draw a tentative design on the design sheet for a removable partial denture. You're then ready to go for your RPD consult and treatment planning session. The first step in planning the antero-posterior rotational path RPD for replacement of the anterior teeth is to get a good set of diagnostic casts for survey and design planning. Start your survey by placing your cast on the surveyor table with a 0-degree tilt to determine the adequacy of undercuts on the mesial surface of the 2 anterior abutments and on the distobuccal surface of the posterior abutments. If this were a mandibular cast, the molar surfaces would probably be the distolingual or the mesiolingual surfaces. The cast is then tilted upward anteriorly until the undercuts on the mesial surfaces of the anterior abutment teeth are eliminated. This is the path of draw for the first insertion of the rotational path removable partial denture. The analyzing rod, a divider or compass, is then used to determine whether access still exists for the rest to be seated. If not, additional tooth modifications in addition to the rest preparation is necessary. There must be no interferences for the anterior segment of the casting to go to place along the determined path. The green arrow points out a slight high survey line interference that needs to be adjusted during mouth preparation. In analyzing this on the cast, the RPD is seated initially along a straight path to the center of rotation, point A, which is located at the gingival portion of the rigid retainer. The center of rotation is on the mesial surface of the canine at the point O2 undercut. The RPD is then rotated along an arc A until the conventional clasp engage the distal buccal or distal lingual undercut on the molar. Any tooth interference along that path has to be altered. Note that the chevron shape of the cingulum rest, that rest cannot be too deeply V-shaped or it will provide interference. A preliminary design is made on the diagnostic cast, showing rest areas and any additional tooth modifications. Rest seats and other tooth adjustments, if any, are completed on the patient and the master impression is made and the master cast is poured. The master cast is then resurveyed as before. The master cast is tripoded and labeled first in the position with the 0-degree tilt, which shows the minimum of 0.010 undercut on the mesial surface of the two anterior abutments and the 0.01 undercut on the distal buccal surface of the posterior abutments. This is done using an analyzing rod as a guide for marking two widely spaced lines on the sides of the cast. This line is labeled A, as in the illustration above. The master cast is then tripoded and labeled in the position where the analyzing rod lies flush against the mesial surface of the canines with the table tilted upward in an anterior direction on the surveyor. These lines are labeled B on the sides of the cast as shown in the illustration. The amount of undercut anteriorly should be a minimum of 0.01 inch undercut. The undercut on the molars will be 0.01 inch, though I've also seen a 0.02 in an article, but this is usually used for frameworks that are cast in gold and where the arm can be made to flex because it is very long. A design is drawn on the cast, a prescription prepared, and the case is ready to send to the laboratory. When the framework comes back from the laboratory, the final casting is positioned anteriorly first, then the posterior is seated. The lingual portion of the anterior segment of the partial denture may be all metal as shown with the facings on the lower picture, or it may be constructed as a mesh for plastic and resin and denture teeth to be added as shown in the middle picture. The final try-in of the framework or final prosthesis is completed and the prosthesis is processed if necessary. The anterior-posterior rotational path design may be used replacing posterior teeth bilaterally and eliminating a direct retainer arm on the anterior abutments. This is used when aesthetics is desirable, especially on the maxillary arch. Analysis of the path the partial must take must be determined and the feasibility of this design determined. In addition to the use of the surveyor to determine the undercuts on the teeth to be clasped, a divider or a compass may be helpful in determining the amount of blockout necessary to eliminate interferences in the seating of the framework. One point of the divider is placed on the axis around which the framework will rotate into position. The other point is placed at the most cervical portion of the tooth at which the rigid retainer will be located. The cervical point of the divider is then rotated occlusally to determine that the minor connector is not in too deep of an undercut to rotate out of the area posterior to the abutment. The point of the divider should be able to move smoothly without interference. With one point of the divider remaining on the axis of rotation, A, The other point is extended to the marginal ridge of the other abutment tooth on the same side of the arch and is rotated cervically to determine the amount of blockout which must coincide with the arc of rotation. This point around which the partial rotates is designated as A. The arc of rotation is designated on the picture with an arc labeled A'. The small area labeled B on the picture is the area that must be blocked out when the framework is made in order to allow the rotational path partial to seat properly. When you survey a cast for the AP rotational path, replacing the posterior teeth bilaterally, it is done with a 0-degree tilt to determine the proper undercut on the tooth to be clasped. We're going to switch over and talk about the posterior-anterior rotational path RPD replacing posterior teeth bilaterally. It's used mainly for mesial-tipped molars when clasping would be difficult without mutilating teeth in preparation for conventional clasping, but it can be also used if we want to improve a patient's oral hygiene by eliminating clasp. A similar procedure is used in designing the RPD as is used with the anterior-posterior path RPD, replacing the posterior teeth bilaterally. The long occlusal rest isn't essential if the molar is tipped mesially. The posterior-anterior rotational path replacing posterior teeth bilaterally is used mainly for mesially tipped molars when clasping would be difficult. This is a graphic illustration of how the RPD functions. The first thing that is done, just like the anterior-posterior path RPD, one point of the divider is placed on the axis around which the framework will rotate, and we labeled it A. The other point is placed at the cervical portion of the tooth at which the rigid retainer will be located. We're calling it A'. The cervical point of the divider is then rotated occlusally to determine that the minor connector is not into too deep of an undercut to rotate out of the area around the axis of rotation. The point of the divider should be able to move occlusally without interference. This particular framework did not rotate well when tried in the mouth. There were interferences and the retentive component was in too deep of an undercut. That retainer must be at least a 0.01 undercut position. It can be into a deeper one, but not so deep that you can't rotate out of it. With one point of the divider remaining on the axis of rotation, point A, the other point is extended to the marginal ridge of the other abutment tooth on the same side of the arch and is rotated cervically to determine the amount of blockout which must coincide with the arc of rotation. The blockout is labeled by that arrow for B. The rotational path RPD may have multiple edentulous areas, but it obviously complicates the prosthesis. The closer the edentulous area is to the center of rotation of the point around which it rotates, point A, the greater the amount of blockout that is needed to be able to seat the rigid retainers. The lateral rotational path RPD is used for replacement of the anterior or posterior teeth or both. A thorough understanding of the AP and PA paths of rotation permits you to utilize the concepts you have seen applied to those designs to be utilized and be pertinent to the design of the lateral path of rotation RPD. A couple of casts and castings are shown to illustrate. Here's a typical cast where the lateral rotational path design can be used. It has a unilateral edentulous area. Shown here are two different designs for this rotational design. The one should be more aesthetic, but the other one provides more stability. This picture shows the path of insertion of the RPD. It's seated first on the facial of the patient's left side, and then it's rotated into position on the opposite side. This is a view of the casting fully seated. The metal retainers extend to engage the distal buccal undercut of the bicuspid and the mesial buccal undercut of the molar. This has buccal retention, so the other side, the direct retainers, have to be on the buccal side of those teeth. Note that the direct retainer arms are on the opposite side of the arch. They are on the buccal surfaces to maintain balanced retention. Could the direct retainer arms be on the lingual surfaces of these teeth? They could be if you placed your rigid components on the patient's left side, on the distal lingual and the mesial lingual surface. It has to satisfy balanced retention. Here is a picture of that anterior unilateral edentulous space that can be utilized for the rotational path. Here are a couple of the designs that can be utilized in this particular case. The pointer is showing the retentive area on the distal labial surface of the central incisor. Teeth have been added to the framework. It looks to be a case where facings may have been used to replace the missing teeth. Base attachment may also be utilized in this type of case. This presentation doesn't imply that all missing teeth should be replaced with an RPD. That there are superior ways of replacing these missing teeth that are available today. It does present another option for you and your patient to develop a treatment plan that suits the aesthetic needs as well as his financial needs. Another type of partial denture that is sometimes used and is also tested on the boards is the swing lock design partial denture. It consists of a labial or a buccal bar that's connected to the major connector at one end by a hinge, and at the other end it has a latch that locks into place. The support of the partial denture is provided by many rests on the remaining natural teeth or crowns. Retention is obtained by the labial bar, which has these projections as shown on that upper picture that go into the undercuts on the buccal or labial surfaces of the remaining teeth. Sometimes acrylic resin may be used as the retentive component, as shown on the left of that upper picture. An advantage of using the swing lock RPD is that it's a relatively inexpensive way for using all the remaining natural teeth for retention and stabilization of the prosthesis, and there's a limited amount of teeth. It's also used when the alternative may only include 1, removal of all the remaining natural teeth. 2, you would have to splint all the remaining natural teeth in order to provide a regular removable partial denture. Or 3, implant placement would be necessary to gain the proper retention and stabilization of the conventional prosthesis. Some of the disadvantages of the swing lock include it can be relatively a poor restoration as far as an aesthetic outcome is involved. Getting a good result with a resin veneer may be difficult because of the path of insertion or placement of the prosthesis is dependent upon that hinge. Also, the remaining teeth are really secured pretty firmly in place by the prosthesis, and a long extension base provides significant forces on those remaining natural teeth. Let's look at some of the indications for the swing lock. When do you use it? It's often used when you have a key abutment tooth that's missing. You might see that a canine is missing on one side and only the 4 incisors remain with, say, an additional tooth that could be the canine or a couple of additional teeth like the canine or 1 or 2 premolars. It may be used when some teeth have questionable prognosis. They may have had some resorption of bone around them, and the prosthesis may be used in a way for periodontal splinting. Often, they have been selected when there are too few remaining teeth for the conventional RPD. Sometimes it's the position of the remaining natural teeth that drive you to use a swing lock. For instance, they may be very labially inclined, and the hinge allows us to use those, whereas conventional clasping may not be available. The contraindications for use of the swing lock are poor oral hygiene or lack of motivation, and if a patient has a real shallow buccal vestibule or labial vestibule. I think the swing lock has probably disappeared more from use also because of the fact that more people are selecting the option of implants for retention of the partial on the one side, which negates having to have all of that metal in the mouth for a partial denture. The lingual plate major connector is the major connector of choice when you have a mandibular swing lock removable partial denture. Other design factors now include if you have a maxillary swing lock, then full palatal coverage is indicated for the maxillary partial denture, or at the very least an anterior posterior palatal strap major connector with the addition of plating on the anteriors. The path of insertion for the swing lock is from the lingual with the hinge in an open position. All of the teeth have to be contacted by the framework, both anteriorly and on the lingual side of them, and they work together to prevent movement of the partial denture. Rests are usually placed adjacent to the edentulous areas, but if you have two premolars, an additional rest is placed on the mesial of the first premolar. Alginate with a custom tray is the impression method of choice. Often, resorption of the bone has taken place around the remaining natural teeth, and rubber base or polyvinyl siloxane get caught too easily into the embrasures, making it almost impossible to remove the impression without tearing it. You need to get a good impression in the labial vestibular area, so it's suggested that a heavy-bodied alginate be used for this, if it's available, or less water to the powder ratio in order to obtain a viscous material for your impression. This helps to get a really good impression of that labial or buccal vestibule. Also, what is very important is that an altered cast procedure be done in the distal extension area. This will help prevent depression of that posterior extension base and prevent rotation around the fulcrum when the partial is in function. When developing occlusion, you need to think of ways to minimize lateral rotational forces of the prosthesis to prevent damage to those few remaining natural teeth. To do this, you ought to think about avoiding deep intercuspation with anatomical teeth. You may want to use something like either lingualized occlusion, or you can use cusped teeth over a flat plane on the mandible. It's also important that you get simultaneous contact of the natural teeth and the denture teeth. You do not want to have premature contact with the posterior teeth on the extension bases. There are definitely some things to think about as far as post-delivery care for the swing lock prosthesis. First of all, oral hygiene is essential because of the extensive amount of metal that is touching the teeth on both sides. You know, metal doesn't necessarily cause any damage, but if the patient doesn't take care of those teeth that are under all of that metal, then you're going to foresee a possible problem later down the road. They need to have regular checkups also, not only to observe the dental hygiene, but to observe the fit of the extension bases. If there's a rotation around that fulcrum line, then that posterior area of the extension base may need to be relined. So you will reline it when it's necessary. Also, the hinge sometimes comes unadjusted and it may loosen up the partial denture, but it is very easy to fix. You do a little bit of a bend to it and you can get it back to a retentive state. If a patient does happen to lose a tooth during the wear of this prosthesis, it's relatively easy to replace a tooth on the swing lock removable partial denture. That's one advantage. This is an example of a rotational path that was done in the clinic. First of all, in the upper left, you can see the illustration showing how this partial denture will work. The anterior portion of the partial will be seated first, as shown also in the picture on the lower left, and then the partial will be rotated into position. The direct retainer arms are located only on the posterior molars, and they must be located in that cervical 1/3. So the partial is placed into position in the anterior first, then it is rotated up into position to engage those posterior direct retainers. The seated partial is shown in the upper right, and you can see on the lower right the aesthetic qualities of the rotational path removable partial in that it has no anterior clasping.